Welcome to week 3, and today we will be covering chapter 27, Assessment of the Cardiovascular System. The key concepts or learning outcomes for this lesson include utilizing knowledge of anatomy and physiology to perform a focused assessment of the cardiovascular system, teach evidence-based health promotion activities to help prevent cardiovascular health problems or trauma, demonstrate clinical judgment to interpret assessment findings in a patient with a cardiovascular health problem, identify factors that affect health equity for patients with cardiovascular health problems, explain how genetic implications and physiologic aging of the cardiovascular system affects perfusion, and plan evidence-based care and support for patients undergoing diagnostic testing of the cardiovascular system. Going back to the idea of assessing the anatomy and physiology, this is the surface anatomy of the heart. More important for our lesson this week is the blood flow through the heart. So the image on the right identifies the blood flow through the heart with dark arrows showing the passage of unoxygenated blood, with the white arrows showing oxygenated blood. The right atrium receives deoxygenated blood from the venous system, which is returned from the blood flow from the superior and inferior vena cava. It also receives blood from the heart muscle through the coronary sinus. Most of the venous return flows passively from the right atrium through the open tricuspid valve and to the right ventricle during ventricular diastole or filling. The right atrium actively propels the remaining venous return into the right ventricle during the atrial systole or contraction. The right ventricle is the muscular pump located behind the sternum. It generates enough pressure to close the tricuspid valve, open the pulmonic valve, and propel blood into the pulmonary artery and the lungs. After blood is reoxygenated in the lungs, it flows freely from the 4 pulmonary veins into the left atrium. Blood then flows through an open mitral valve into the left ventricle during ventricular diastole. When the left ventricle is almost full, the left atrium contracts, pumping the remaining blood volume into the left ventricle. With systolic contraction, the left ventricle generates enough pressure to close the mitral valve and open the aortic valve. Blood is propelled into the aorta and the systemic arterial circulation. There are 4 cardiac valves, and they are responsible for maintaining the forward flow of blood through the chambers of the heart. These valves open and close when pressure and volume change within the heart's chambers. The cardiac valves are classified into 2 types: arterioventricular or AV valves and semilunar valves. The arterioventricular valves separate the atria from the ventricle. The tricuspid valve separates the right atrium from the right ventricle. The mitral or bicuspid valve separates the left atrium from the left ventricle. During ventricular diastole, these valves act as funnels and help move the flow of blood from the atria to the ventricles. During systole, the valves close to prevent the backflow or valvular regurgitation of the blood into the atria. The semilunar valves are the pulmonic valves and the aortic valve, which prevent blood from flowing back into the ventriculars during diastole. The pulmonic valve separates the right ventricle from the pulmonary artery. The aortic valve separates the left ventricle from the aorta. Coronary artery blood flow to the myocardium occurs primarily during diastole, when coronary vascular resistance is minimized. To maintain adequate blood flow through the coronary arteries, mean arterial pressure, or something referred to as the MAP, must be at least 60 millimeters of mercury. A MAP between 60 and 70 millimeters of mercury is necessary to maintain perfusion of major body organs, such as the kidney and the brain. Let's go into the sequences of events during the cardiac cycle. The phases of the cardiac cycle are generally described in relation to changes in pressure and volume in the left ventricle during filling, or diastole, and ventricle contraction, or systole. Diastole consists of relaxation and filling of the atria and ventricles and comprises about 2/3 of the cardiac cycle. Systole consists of the contraction and emptying of the atria and ventricles. Myocardial contraction results from the release of large numbers of calcium ions from the sarcoplasmic reticulum and the blood. These ions diffuse into the myofibril sacrame, the basic contractile unit of the myocardial cell. Calcium ions promote the interaction of actin and myosin protein filaments, causing the filaments to link and overlap. Cross bridges or linkages are formed as the protein filaments slide over and overlap each other. These cross bridges act as force-generating sites. The sliding of the protein filament shortens the sacrames, producing myocardial contraction. Cardiac muscle relaxes when calcium ions are pumped back into the sarcoplasmic reticulum, causing a decrease in the number of calcium ions around the myofibrils. This reduces the number of ions, causing the protein filaments to disengage, the sarcomere to lengthen, and the muscle to relax. Some key terms for this chapter are the mechanical properties of the heart. So the first term is cardiac output, sometimes referred to as CO. This is the volume of blood ejected by the heart each minute. The next one is heart rate, or HR. This is a term referring to the number of times the ventriculars contract each minute. Then we have stroke volume, or SV. This is the amount of blood ejected by the left ventricle during each contraction. When we talk about preload, that's the degree of myocardial fiber stretch at the end of diastole and just before contraction. When we talk about afterload, that is the pressure or resistance that the ventricles must overcome to eject blood through the semilunar valves and into the peripheral blood vessels. So the term cardiac output is going to come in handy much more next semester for MedSurg 3, but this is the amount of blood pumped through the left ventricle per minute. So in adults, the cardiac output ranges between 3 to 6 liters per minute. Because cardiac output requires vary according to body size, the cardiac index is calculated to adjust for differences in body size. So the cardiac index can be determined by dividing the cardiac output by the body surface area. The normal range is 2.8 to 4.2 liters per minute per M2, and the formula for that is cardiac output equals heart rate times stroke volume. So now let's talk about the vascular system. The vascular system serves several purposes. It provides a route for blood to travel from the heart to nourish the various tissues of the body. It carries cellular waste to the excretory organs. It allows lymphatic flow to drain tissue fluid back into the circulation. It returns blood to the heart for recirculation. The vascular system is divided into the arterial system and the venous system. In the arterial system, blood moves from the larger arteries to a network of smaller blood vessels called arterioles, which meet the capillary bed. In the venous system, blood travels from the capillaries to the venules and to the large system of veins, eventually returning in the vena cava to the heart for recirculation. So let's divide this even further. Now we'll talk about the arterial system. This is the primary function of the arterial system is to deliver oxygen and nutrients to various tissues in the body. Nutrients are carried through arteries to arterioles, then branches into smaller terminal arterioles, and finally join with the capillary and venules to form a capillary network. Within this network, nutrients are exchanged across capillary membranes by 3 primary processes. These are osmosis, filtration, and diffusion. How does the nurse see this? This is seen in blood pressure. Let's talk about blood pressure regulation. Blood pressure, sometimes listed as BP, is the force of blood exerted against the vessel walls. Pressure is, in the larger arterial blood vessels, is greater, so about 80 to 100 millimeters of mercury, and decreases as blood flow reaches the capillaries, where it ends up being about 25 millimeters of mercury. By the time blood enters the right atrium, the blood pressure is about 0 to 5 millimeters of mercury. Volume, ventricular contraction, and vascular tone are necessary to maintain that blood pressure. Blood pressure is determined primarily by the quantity of blood flow or cardiac output and by the resistance of the arterioles. Any factor that increases the cardiac output or total peripheral vascular resistance increases the blood pressure. In general, blood pressure is maintained at a relatively constant level. Therefore, an increase or decrease in total peripheral vascular resistance is associated with a decrease or an increase in cardiac output. respectively. Three mechanisms mediate and regulate our blood pressure. That would be the autonomic nervous system, or the ANS, which excites or inhibits sympathetic nervous system activity in response to impulses from chemoreceptors and baroreceptors. The kidneys are our second one, which sense a change in blood flow and activate the renin-angiotensin-aldosterone mechanism. And the last and third is the endocrine system, which releases various hormones, catecholamines, kinins, serotonin, histamines, to stimulate the sympathetic nervous system at the tissue level. Systolic blood pressure is the amount of pressure or force generated by the left ventricle to distribute blood into the aorta with each contraction of the heart. It is a measure of how effectively the heart pumps and is an indicator of vascular tone. Diastolic blood pressure is the amount of pressure or force against the arterial walls during the relaxation phase of the heart. Blood pressure is regulated by balancing the sympathetic and the parasympathetic nervous system of the ANS, or again, autonomic nervous system. Changes in autonomic activity are responses to messages sent by the sensory receptors in the various tissues of the body. These receptors, including the baroreceptors, chemoreceptors, and stretch receptors, respond differently to the biochemical and physiological changes of the body. Baroreceptors in the arch of the aorta and at the origin of the internal carotid arteries are stimulated when the arterial walls are stretched by an increased blood pressure. Impulses from the baroreceptors inhibit the vasomotor center, which is located in the pons and the medulla of the brain. Inhibition of this center results in a drop in blood pressure. The primary function of the venous system is to complete the circulation of blood by returning blood from the capillaries to the right side of the heart. It is composed of a series of veins that are located next to the arterial system. A second superficial venous circulation runs parallel to the subcutaneous tissue of the extremity. These two venous systems are connected by communicating veins that provide a means for blood to travel from the superficial veins to the deep veins. Blood flow is directed toward the deep venous circulation. Veins can accommodate large shifts in volume with minimal changes in venous pressure. The flexibility allows the venous system to accommodate the administration of IV fluids and blood transfusions and to maintain pressure during blood loss and dehydration. Veins in the superficial and deep venous system, except for the smallest and the largest veins, have valves that direct blood flow back to the heart and prevent backflow. Skeletal muscles in the extremities provide a force that helps push the venous blood forward. The superior vena cava and the inferior vena cava are valveless and large enough to allow blood flow to return easily to the heart. Let's talk about some key changes that happen to the cardiovascular system associated with aging. There are many of these changes, and they result in a loss of cardiac reserve. These changes are usually not evident when the older adult is resting. They're more apparent when the patient is physically or emotionally stressed and the heart cannot meet the increased metabolic demands of the body. Calcification and mucoid degeneration occur, especially in the mitral and the aortic valves. Pacemaker cells decrease in number. Fibrous tissue and fat in the SA or sinoatrial node increases. Few muscle fibers remain in the atriomyocardial and the bundle of His. Conduction time increases. The size of the left ventricle increases. The left ventricle becomes stiff and less distendable. Fibrotic changes in the left ventricle decrease the speed of early diastolic filling by about 50%. The aorta and the other large arteries thicken and become stiffer and less distendable. Systolic blood pressure increases to compensate for the stiff arteries. Systemic vascular resistance increases because of less distendable arteries, and the left ventricle pumps against greater resistance, contributing to left ventricular hypertrophy. Baroreceptors become less sensitive. So let's look at some of the cues we need to recognize. We'll start with our assessment. When we talk about the term DOE, that is dyspnea on exertion. When we talk about the term PND, that is paroxysmal nocturnal dyspnea. Modifiable risk factors are personal lifestyle habits, including cigarette smoking, physical activity, obesity, and psychological variables. Ask the patient about each of these common risk factors. Cigarette smoking is a major risk factor for coronary vascular disease, specifically coronary artery disease, and peripheral vascular disease, or PVD. 3 components in cigarette smoke have been implicated in the development of coronary artery disease, and that is tar, nicotine, and carbon monoxide. The smoking history should include the number of cigarettes smoked daily, the duration of the smoking habit, and the age of the patient when smoking started. Record the smoking history in pack per year, as we've learned in our previous lessons, which is the number of packs per day multiplied by the number of years of the patient has smoked. To foster smoking cessation, the Center for Disease Control and Prevention, or the CDC, recommends that the healthcare provider use the 5 algorithm. The 5 algorithm approach, or 5A, was discussed in Chapter 22, but here it is again in relation to the significant cardiovascular risk. So the 5 A's are: we ask the patient about tobacco use, we assess the patient's desire to quit, past attempts to quit, and the method used, we advise the patient to quit, we talk about how tobacco use is one of the largest preventable causes of death in the United States, we assess their readiness for quitting, we assist by providing resources, and we arrange for follow-up. So non-modifiable or uncontrolled risk factors for this would be age, sex assigned at birth, ethnic origin, and a family history for cardiovascular disease. Moving right along in our assessment findings, we're going to start with our physical assessment. We're going to ask the patient to identify when the symptoms were first noticed or the onset. Did the symptoms begin suddenly or did they develop gradually? So what's the manner of the onset? How long did the symptoms last? So what's the duration? If the patient has repeated painful episodes, we need to assess how often the symptoms occur or the frequency. If pain is present, ask whether it is different from any other episodes of pain. Ask patients to describe which activities they were doing when the pain first occurred, such as sleeping, arguing, or running, which would be the precipitating factors. If possible, the patient should point to the area where the chest pain occurred or the location, and describe if and how the pain radiated or spread. In addition, we want to ask how the pain feels and where it is sharp, dull, or crushing, so the quality of the pain. To understand the severity of the pain, we need to ask the patient to grade it on a scale of 0 to 10, with 10 indicating severe pain or the intensity. Patients may also report other signs and symptoms that occur at the same time or associated symptoms such as dyspnea, diaphoresis, excessive sweating, nausea, and vomiting. Other factors that may need to be addressed are those that have made the chest pain worse, or aggravating factors, or less intense, relieving factors. Chest pain can arise from a variety of sources. Some patients, especially female patients, do not experience chest pain the same as men, but they will feel intense discomfort or indigestion. Female patients often present with a triad of symptoms. In addition to indigestion or feeling of abdominal fullness, chronic fatigue, despite adequate rest, and feelings of an inability to catch my breath, or dyspnea, are all common in heart disease. The patient may also describe the sensation of aching, choking, strangling, tingling, squeezing, constricting, or a vice-like feeling. So let's recognize some cues. When we talk to our patient, we're going to talk about their coping factors and any major life crises. So the patient and family confront not only the possibility of death, but also fear about pain, disability, lack of self-esteem, physical dependence, and changes in their family dynamics. A common and normal response to this is denial, which is a defense mechanism that enables the patient to cope with threatening circumstances. The patient may deny the current cardiovascular conditions. They may state that it was present but is now absent, or may be excessively cheerful. Denial becomes maladaptive when the patient is non-adherent to the interprofessional plan for care. Let's do our laboratory assessment. When we're looking at a patient and we're worried about our cardiovascular system, there's several labs that we will assess. The first one is their lipid panel. We assess their cholesterol. We want to see that that's less than 200 milligrams per deciliter. Elevations indicate an increased risk for coronary artery disease. For triglycerides, we want to see in females that it's 35 to 135 milligrams per deciliter. Males, 40 to 160 milligrams per deciliter. Elevations indicate an increased risk for coronary artery disease. We want to look at their plasma high-density lipoproteins. For females, we want to see that those HDLs, or the healthy fats, are greater than 55 milligrams per deciliter in females and greater than 45 milligrams per deciliter in males. Older adults, range increases with age. If we see elevation, it protects against coronary artery disease. When we look at LDLs, or the lousy lipoproteins, we want to see that they're less than 130 milligrams per deciliter. Elevations indicate an increased risk for coronary artery disease. The HDL to LDL ratio should be 3 to 1, so we want 3 healthy fats for 1 bad fat. Elevated ratios may protect against coronary artery disease. When we talk about the very low density lipoproteins, or the really yucky ones, we want to see that that is between the level of 7 and 32 milligrams per deciliter. Elevated levels indicate a risk for coronary artery disease. The next thing we'll look at is a C-reactive protein, and we want to see that that is less than 1.0. Elevations may indicate tissue infarction or damage. And then the last thing we look at are the serum markers, which would be the troponins. The specific one for the cardiac system is a cardiac troponin. We want to see that it's less than 0.1 NGs per ml, and a cardiac troponin 1 should be less than 0.03. And elevated indicates that there's been a myocardial injury or infarction. Our final portion of our assessment for the cardiovascular system would be the diagnostic assessments. So this would be our chest x-rays, our contrast media scans. So we'll just delve into this. So CXR stands for chest x-ray when you see that, and then PA is a posterior anterior. So a posterior anterior and a left lateral x-ray views of the chest are routinely obtained to determine the size, silhouette, and position of the heart. And acutely ill patients, a simple anterior posterior or AP view may be obtained at the bedside. Cardiac enlargement, pulmonary congestion, cardiac calcifications, and placement of central venous catheters, endotracheal tubes, and hemodynamic monitoring devices can be assessed by X-ray. Angiography of the arterial vessels, or angiography, is an invasive diagnostic procedure that involves fluoroscopy and the use of contrast media. This procedure is performed when an arterial obstruction, narrowing, or aneurysm is suspected. The interventional radiologist performs selective angiography to evaluate specific areas of the arterial system. For example, coronary angiography, which is performed during left-sided cardiac catheterization, assesses arterial circulation within the heart. It can also be performed on arteries in the extremities, mesentery, and cerebrum. So MedSurg 3 goes more into the cardiac catheterization, but I wanted to take a minute and a slide just to kind of cover the basics of it. So what are the indications for a cardiac catheterization? When we do a cardiac catheterization, that is to confirm suspected heart disorder, including congenital abnormalities, coronary artery disease, myocardial disease, valvular disease, and valvular dysfunction. We use this to determine the location and extent of the disease process. It's used to assess, so stable, severe angina, unresponsive to medication management, unstable angina pectoris, uncontrolled heart failure or ventricular dysrhythmias, or a cardiogenic shock associated with acute myocardial infarction, papillary muscle dysfunction, and ventricular aneurysm or a septal perforation. To determine the best therapeutic option, percutaneous transluminal coronary angioplasty, stents, coronary artery bypass graft, or valvulotomy versus valve replacement. To evaluate effects of medical or invasive treatment on the cardiovascular function, percutaneous transluminal coronary angioplasty or a coronary artery bypass graft patency. Other diagnostic assessments that we can utilize are an ECG or electrocardiogram, a TEE or a transesophageal echocardiogram. So the ECG is a routine part of every cardiovascular evaluation as one of the most valuable diagnostic tests. Various forms are available. We can do a resting ECG, a continuous ambulatory ECG or a Holter monitoring, exercise ECGs or stress tests, or signal averaged ECGs and a 30-day event monitoring. When we talk about this study of this, that's called EPS, or electrophysiologic studies. And this is an invasive procedure during which programmed electrical stimulation of the heart is used to cause and evaluate lethal dysrhythmias and conduction abnormalities. Patients who have survived cardiac arrest, have recurrent tachydysrhythmias, or experience unexplained syncopal episodes may be referred for an EPS. Induction of the dysrhythmia during the EPS helps find an accurate diagnosis and aids in effective treatment. Exercise ECG tests, also known as exercise tolerance tests or stress tests, assess cardiovascular response to an increased workload.